Good evening. Welcome to this Research to Practice program, Beyond the Guidelines. Urologic oncology investigators provide perspective on the optimal management of prostate cancer. I'm Dr. Matthew Smith from Massachusetts General Hospital Cancer Center in Boston. I'm pleased to be joined by an outstanding faculty, including Himisha Beltran from Dana-Farber Cancer Institute, Stephen Freedland from Cedars-Sinai, Fred Saad from University of Montreal, Neal from Carolina Urologic Research Center. This promises to be a lively and entertaining program, and we're pleased to have your active participation for both of those of you here in person as well as the many folks joining us online. We thank our commercial supporters for this program. We also thank the Research to Practice CME Planning Committee members, staff, and reviewers. This is our agenda, Module 1, Management of Approaches to Non-Metastatic Prostate Cancer. Second module will focus on metastatic hormone-sensitive disease. Third module will be Therapeutic Considerations for patients with newly diagnosed prostate cancer. Fourth module will be Contemporary Management in mCRPC in patients with HRR gene mutations. Then we'll close with Current and Emerging Strategies in the Treatment of Recurrent mCRPC. This slide summarizes the prostate cancer survey respondents. You'll see cases presented and the responses from these panelists. Our first module is Management Approaches to Non-Metastatic Prostate Cancer. And we're going to begin each module with a discussion question. So the question we have for today is, what is your take on the EMBARK study, particularly the enzalutamide alone arm? Dr. Shore, would you like to take that question? Congratulations on your presentation at this meeting.
Well, thank you very much. For the enzalutamide monotherapy arm alone, in comparison to traditional leuprolide acetate monotherapy, hazard ratio 0.63, which met the statistical significance in the primary endpoint of metastasis-free survival. So a successful comparison in this three-arm trial. I think that we saw some differences in tolerability, unopposed AR blockade without T suppression. You saw some more gynecomastia, which you saw in your trial that you did, Matthew, a few years ago with unopposed enzalutamide oral monotherapy, and we saw that in ENACT. We have some PROs that we'll be presenting, Steve Freedland and I, but overall a successful trial with that particular arm.
So EMBARK was a study of patients with non-metastatic hormone-sensitive disease, non-metastatic being defined by conventional imaging. So Dr. Beltran, how do we put the results of this study in the context of what we already know from mHSPC by conventional imaging?
Yeah, well, it was really nice to see this practice-changing study presented, and it really kind of confirms that what we know about metastatic hormone-sensitive, that adding a potent AR pathway inhibitor to a backbone of ADT is better than monotherapy, and many of these patients now at higher risk for developing metastatic disease may already have micrometastatic disease on PSMA PET scan, and so essentially EMBARK is just saying that we should be treating earlier with potent AR drugs as they improve outcomes. I think I'd love to commend the investigators. I think that the difference here also is that this was an intermittent approach, which is our standard of care for biochemical recurrent disease, and so this, I think, has an advantage of coming in early and the opportunity to come off of therapy for some individuals. I think the question of the doublet versus the enzalutamide alone is really, I think, going to come down to quality of life and who are those patients that are really going to benefit from monotherapy that we haven't seen before.
Dr. Saad, are there any caveats from this study? Are there concerns about the study design? Anything else that we should consider in how we might apply this evidence to clinical practice?
No, honestly, I think the trial was designed very pragmatically. I think it addresses an important question. I think the things that we have to keep in mind is that these were really high-risk patients. So I wouldn't say that this is applicable to every patient with biochemical recurrence, and it's our responsibility not to overtreat patients that are unlikely to suffer. But I think the take-home message is this adds to the evidence that if somebody truly needs ADT, we need to do better than ADT alone. And we're seeing this consistently, one trial after that confirms that if patients are going to suffer, develop metastases, and eventually possibly die from the disease, you have to do the very best you can up front.
Dr. Freedland, your thoughts?
Yeah, no, I agree. I keep saying I want to live in a world where ADT is ADT plus an AR-targeted therapy. And we know that in mCRPC, we know that in mCSPC, non-metastatic CRPC, we now know it for high-risk BCR. The one other place where we use ADT with good evidence is in radiation patients. Those trials are ongoing, but I think if those studies are positive, and I have every reason to believe they are, this is just the way we should do ADT. And to Fred's point, not everyone needs ADT, but if you do it right.
Yeah, I think that's really a great point. And we do await the results of these trials of patients being treated with curative intent, but we do have some evidence already from Stampede, right, of addition of abiraterone in patients with very high risk and regional risk prostate cancer receiving ADT and radiation, part of NCCN guidelines. And I think you're right, we really need to change the terminology, right? So current ADT is more than a GnRH agonist or antagonist. It really needs to be combination therapy. So I think really important takeaway message. It's also remarkable, I think, how there's sort of convergence of the field, right? So this terminology, metastatic, non-metastatic, altered ways of defining these disease states by conventional and PSMA PET scan, in many ways lead down the same path because we have separate evidence about the importance of treating the primary tumor, for example, in patients with low volume de novo metastatic disease. So we're going to move on to cases. This will be a part of each of the sections, and we'd like to thank Drs. Hafren and Morris for contributing these cases from their practice. These are derivatives or real cases, and we appreciate that. And so they can find them to be very practical in the way we think about managing prostate cancer. So the first case is a 66-year-old man who presents with Gleason 4+4 disease. PSA is 12.7, bone scan is negative. CT imaging reveals uptake in pelvic nodes. And the question is, what approach to primary therapy would you most likely recommend for this patient? So NCCN regional risk prostate cancer, Gleason 8, PSA 12, node positive by conventional imaging. The choices were external beam radiation therapy as primary treatment or radical prostatectomy. You see most respondents voted for radiation, but not all. Dr. Saad, is there a role for prostatectomy in patients who are clinically node positive?
So there is always a role with a shared decision, but most of my patients would get radiation therapy rather than radical prostatectomy. But we have done this kind of approach, knowing that surgery would not cure the patient alone. In patients in their 40s, very aggressive approach in a tumor board setting. But for the average patient, I would agree that external beam radiation plus hormone therapy, intensified probably, would be my first choice.
Dr. Freedland, would you offer surgery to a patient similar to the described in this case here?
Absolutely. To Fred's point, it's shared decision-making for sure, and it's always tough of what you'd recommend because we try to be a little more agnostic and present the data. Have I operated on patients like this? Yes. And I do think there's a role for surgery. We see, Fred, you say surgery is not curative. I would argue radiation's not going to be curative if we have nodal disease. So we have randomized trial data, not in this patient population, but in others. Surgery and radiation are equivalent. I would imagine they're equivalent in this. Probably going to need some sort of systemic therapy at some point, which should be intensified, we now know, but I would definitely offer it as part of shared decision-making.
Dr. Beltran, does the evidence from Stampede, for example, that intensification in a patient like this improves survival, does that alter the equation in terms of whether a patient should be offered surgery or radiation therapy? I know that was not the question of the trial, but
right.
We're often confronted with comparing across different clinical trials.
Well, this would have been a patient that would have met eligibility for Stampede M0, and we're intensifying with ADT plus 2 years of abiraterone with the radiotherapy. Similar to the prior discussions, earlier is better, and we don't yet have the data for a post-radical prostatectomy salvage setting. Likely that patient would have need additional therapy, as mentioned, with a pathologic node positive disease, likely salvage or adjuvant adjuvant radiotherapy plus 2 years of ADT based on radicals HD, and we still don't have the data for abiraterone, and this is a patient where I think is really at high risk that I'd like to bring in a potent AR therapy even earlier.
I certainly share the views of my fellow panelists. What we would advise a patient like this is no single therapy will be curative, and they're going to need multidisciplinary care. And many patients like this we would offer surgery to, but with the full understanding that they will require subsequent treatment. Our next case is a 61-year-old man who presents with Gleason 4+4 disease. He undergoes robotic prostatectomy. Final pathology reveals T3BN1 disease with 2 of 10 positive lymph nodes. Regulatory and reimbursement issues aside, would you recommend hormonal therapy at this point? Although not specified in the case, well, I'll let you, in your answers, comment on the role of postoperative PSA result in informing this decision. But Dr. Shore, what would you advise such a patient?
So I would probably, I think I would go with ADT and abiraterone, given these low volume disease. And I think that, both Latitude and Stampede arm would support that. I would offer that. I don't think I would just do monotherapy ADT.
Dr. Beltran?
Yeah, I would do that in combination with radiotherapy for a patient with, I think, at least consider it or discuss that with a patient with 2 of 10 lymph nodes and in this sort of a salvage situation.
Dr. Freedland?
Yeah, I was going to add to what Misha said. I think it's important to consider the radiation, whether it's salvage or adjuvant. We can debate semantics. There is some retrospective data that in node positive patients post-prostatectomy, that radiation can improve outcomes. So I would do it with aggressive ADT, as we're learning now, but don't forget the salvage radiation.
Yeah, I think it's a good point. This kind of brings to the issue of the convergence of our systemic and local therapies, right? So patients need really good local control. And there is a clear and consistent evidence for improved outcomes by intensified systemic treatment by addition of an AR pathway inhibitor. Dr. Saad, what are your thoughts here?
Yeah, I agree. I mean, clearly, I would avoid trying to keep this patient on systemic therapy for the rest of their life. So that's why we would give radiation. We've had several of these patients that have done very well with radiation. More likely in the adjuvant setting, I think he wouldn't have a PSA of undetectable, but even if he does, this is the kind of patient we would do adjuvant, even considering radicals, and we would try to give a short-term intensive ADT and abiraterone in the range of about a year, and then see what happens in this. This is relatively low volume N1 disease.
And you can see each of the respondents provided their thoughts about optimal duration of hormonal therapy. There is a range there, but sort of most of them converged around 24 months. Our next case is a 64-year-old man who underwent prostatectomy about 5 years ago for Gleason 4+5 disease. Pathology reported PT2N0 with negative margins. His post-surgical PSA was initially undetectable, but then rose to 0.2. He undergoes salvage radiation therapy to the pelvic, to the prostate fossa and pelvic nodes, and receives concurrent androgen deprivation therapy. Despite that salvage therapy, his PSA promptly rises to 0.23 nanograms per ml. Conventional imaging is negative, and then he has a PSMA PET scan that reveals a lesion in the right anterior first rib. We'll specify that that was a compelling finding. And then in addition to radiation therapy to that site, what would be your most likely treatment recommendation? Dr. Beltran?
So I think this is kind of a challenging case in that it's oligometastatic disease, low PSA detected by PSMA PET scan, not clear if it was seen on conventional imaging, also an area where sometimes we see false positives also, but assuming that this is a real lesion and doing radiation therapy, we know that for low volume metastatic disease and high volume, that intensifying is important, as we've discussed, but there is data to think about doing metastasis-directed therapy to delay the need for ADT. And so I think I would discuss options, with the patient and weighing kind of the side effects and the duration of therapy and everything, with this. I think there are certain situations where, in most situations I like to intensify therapy, but there are certain situations where delaying ADT may be, really clinically meaningful for that patient.
Yeah, I agree. Dr. Shore, what are your thoughts here?
Yeah, I'm glad I guess by you saying that the PSMA PET in the rib was compelling, positive rib lesions on PSMA PET or have a high false positive. Ribs are obviously difficult to biopsy. We've had some success if they're pretty large rib lesions, and that makes them particularly compelling. I would agree with Misha, and that I would look for some form of combined therapy.
That's a great point to conclude our first series of cases. We'll now move on to management approaches for non-metastatic prostate cancer. Dr. Freedland.
Great, thank you very much. So we've got a lot of studies here to come through, so we're going to kind of go through these quickly here. We're going to just talk about ADT, when and how to do it. We're going to review the role for novel hormonal therapies, both non-metastatic CSPC and the non-metastatic CRPC. So when and how do we do it? So we still don't know when to start ADT, even for the patient that's clearly going to need it, and we still don't know how to do it, whether to do intermittent or continuous. There are randomized trials showing no difference. They were not stratified by doubling times and variables that we now know are important, whether you do combined or ADT, whether agonist or antagonist. And I do think EMBARK answers some of these, but certainly not all of these questions. So pros and cons to agonist versus antagonist. I'm not going to go through the detail in depth, but I think with the antagonist, you get a rapid C suppression and a return, perhaps reduced cardiovascular risk. So I think in sense makes some sense. These are new medicines, they're oral, that could be both good and bad, but they tend to be more expensive, and urologists, we have Lupron sitting on our shelves and can easily give it to patients, lasts for 3 months. So again, pros and cons. So this was actually tested in a study led by Neal up here, the phase 3 HERO study. And these were basically men needing ADT, randomized to relugolix versus leuprolide. And the primary outcome was at 48 weeks in terms of testosterone sustained castration during that time point. And what we see is here is the percent of patients that get to and have sustained castration was actually better with the relugolix. We tend to think of leuprolide. For many of us, we give a shot. Of course, it works. We don't necessarily check testosterone or think about it. And this was a little bit eye-opening for me, the fact that we're not even hitting 90% sustained castration levels. So again, superiority for the relugolix arm. And the curves are kind of what you would expect. With the leuprolide, testosterone levels actually go up and then come down. If we look at 5 weeks, so we're past a month, we're still not necessarily getting to that castration in all patients. And eventually we get there, but it can take quite a while, whereas with the relugolix, we get there very, very quickly. And then once they stop treatment, the leuprolide keeps on working, as opposed to the relugolix, where you start to see the testosterone is already starting to recover within a few weeks. And very, very intriguing secondary outcome. But what they saw was when they looked at major adverse cardiovascular events, actually saw a lower rate with relugolix relative leuprolide. This has been seen with other studies with degarelix, always as a secondary outcome. The one sole trial that actually looked at this as a primary outcome ultimately closed early and was a negative study, but there's a lot of thoughts that patients were aggressively managed, and that in itself reduced the risks. So I think it's still an unanswered question, but very intriguing. So as we move into the novel hormonal therapies in the non-metastatic space, Stampede has already been mentioned. Basically, it's predominantly radiation patients, and it was a comparison of standard of care, which was ADT with 3 years versus ADT and standard of care with ADT for 3 years, but also adding either abiraterone for 2 or abiraterone plus enzalutamide. And Abi plus enzalutamide was really no better than Abi alone, and so they were able to combine the groups, primarily radiation patients. So about 90% of those were getting primary radiation. If you look at metastasis-free survival, very impressive hazard ratio of 0.53, really important, clinically significant improvement. If we actually look at overall survival, hazard ratio of 0.6. So really, I think for that really high-risk patient undergoing primary radiation, I do think this is the standard of care now. The question is, what if you're just regular high risk? What if you're unfavorable intermediate? Where do we draw that line? Unknown at this point. So PRESTO was a study in the biochemical recurrence setting looking at apalutamide. So these were men who had a PSA recurrence after surgery or radiation, doubling time less than 9 months. This was only surgical patients. And basically they were randomized to ADT plus apalutamide, ADT plus apalutamide and AB. And again, you'll see in a minute the doublet. 2 novel hormonal therapies, really no better than 1. And then the therapy was stopped at 52 weeks, and they were followed for PSA progression, but it's really a castrate-sensitive progression. And what you see here, the hazard ratios are essentially identical, whether it was apalutamide or apalutamide plus ABI, but statistically significant improvement in PSA progression, which again, clinically, I'm not sure exactly how to interpret this. This was formally tested in the EMBARK study, which was presented by Neal so eloquently yesterday. Biochemical recurrent patients, doubling time less than 9 months. 75% of the patients had had surgery, 25% had failed radiation. Again, needing ADT, randomized to enzalutamide plus leuprolide alone, or enzalutamide monotherapy. Very intriguing. We don't have time to necessarily get into it here in the slides, but PSA was measured at 36 weeks. It was less than 0.2. They came off therapy and then ultimately was restarted when they reached certain PSA thresholds. Primary outcome was metastasis-free survival. And what you can see here is a very, very impressive improvement in metastasis-free survival, which is metastasis or death with the Enza plus ADT versus ADT alone, hazard ratio of 0.42, extremely impressive, clinically important. If we look at overall survival, it's interim, but clearly trending in the right direction, hazard ratio of 0.59. It's certainly tempting to look at that p-value of 0.01 and claim it's statistically significant. It is not. Pre-specified efficacy boundary is p less than 0.0001. That's the threshold we needed to call that significant, but clearly trending and moving in the right direction. If we look at the time to PSA progression, this was for me, the slide that was the most wow. If you look at it, the enzalutamide combination therapy, time to PSA progression is almost a flat line. Extremely impressive compared to a slow decline in the control arm with a hazard ratio of 0.07. If we look at the monotherapy arm, what you see is statistically and clinically significant improvement in metastasis-free survival. So enzalutamide with or without ADT was better than ADT. It has a ratio here of 0.63. If we look at OS, quite immature in the data, but also trending in the right direction, has a ratio of 0.77, a nominal p-value of 0.2. And then the most common treatment-related adverse events, hot flashes, fatigue, importantly, and I'm sure we may get into some questions, the enzalutamide monotherapy had fatigue rates that were similar actually to the combination and the leuprolide alone arm. In terms of the non-metastatic CRPC, basically all the trials were very similar in that there were patients with CT bone scan negative, rising PSA, non-metastatic CRPC, doubling time less than 10 months, randomized to some sort of drug. We're going to go through all three really quickly versus placebo with a metastasis-free survival endpoint. This is the enzalutamide PROSPER study, updated data, and this is the OS endpoint, so secondary endpoint, but statistically significant hazard ratio 0.73. If we look at the Spartan study with apalutamide, what you see is a hazard ratio of 0.78, again, very similar. And if we look at the Aramis, which is darolutamide, you see a hazard ratio of 0.69. Again, all three quite similar with the most recent updated data. So in summary, again, for certainly ADT, relugolix is a new standard of care option. And for patients with high-risk bowel column recurrence, I think EMBARK does establish a new standard of care of ADT plus enzalutamide. And we know that novel hormonal therapies certainly benefit MFS and OS and non-metastatic CRPC. And again, my hope is we can live in a world where ADT means ADT plus an AR-targeted agent.
Thank you, Dr. Freedland. We got a really interesting question from the audience as it relates to EMBARK, and that is, given there were 3 arms in EMBARK, one of which was enza monotherapy, does that present a realistic option, Dr. Shore, for a patient who would like to avoid ADT, and would there be an expectation of better quality of life with enza monotherapy compared to, say, ADT alone or ADT plus enza?
Yeah, a very important question. We obtain numerous validated questionnaires and patient-reported outcomes, the PROs. We're reviewing those now. We will have those presented later this year. And I think that's particularly the arm that will be quite fascinating to our colleagues. Avoiding T suppression, just doing a powerful AR blockade with obvious, novel hormonal agents such as enzalutamide. And particularly for patients where sexual function may be high priority, I think this will be a very intriguing option.
Yeah, I think it will be really important to see the phase 3 data. There's a modest-sized phase 2 experience compared to ADT alone, and at least in that setting. Enza monotherapy has most of the physiologic negative side effects of ADT, and at least with that smaller study, had substantial impact on sexual function and other quality of life domains. So the phase 3 study will certainly help define that in a more compelling way. Second module is optimizing the care of patients with metastatic hormone-sensitive prostate cancer. Dr. Beltran, in this disease state, when do you use docetaxel? Who are the appropriate patients to receive docetaxel as part of their systemic therapy?
Yeah, so, metastatic hormone-sensitive prostate cancer is a heterogeneous disease, and we know even within that there are people that have worse prognosis, those with de novo disease, high volume disease, compared to those with metachronous or low volume disease. And there's a wealth of data now, multiple trials that have shown that ADT plus an AR pathway inhibitor is standard of care for all patients, regardless of risk. Who you intensify with docetaxel kind of really depends on where in that spectrum that patient is. And data from the ADT docetaxel versus ADT suggested that patients with high volume disease and de novo high volume disease in particular benefit the most from chemotherapy. And so the trials that looked at triplet therapy had the standard arm was ADT plus docetaxel compared to ADT plus docetaxel plus darolutamide or abiraterone. And so I would only really consider triplet therapy in patients I would have been given docetaxel ADT2, which would have been those high volume, high risk patients. And the trials do look to seem at this point that there is more of a benefit for those patients. And so really those high volume patients defined by the charted criteria, young patients, visceral mets, these types of patients where you know that you need to do more than ADT AR pathway inhibitor alone.
Yeah, so just a quick follow-up question. Are there patient characteristics who maybe not disease characteristics, patient characteristics that would lead you to recommend docetaxel to patients, say, who don't meet the either high volume or high risk criteria?
Yeah, I think that it's a conversation. There is data to suggest that perhaps we are more than just the high volume patients might benefit. I think that I particularly don't like patients that have very low PSAs and kind of sort of unusual sites of mets, although they would meet high volume criteria if they have visceral mets in that situation anyway. Younger patients that want to be aggressive, it's something I would talk to them about.
Very good. Dr. Saad, do you have a preference among the AR pathway inhibitors in this disease state, intensification for MHSPC?
I would say based on what I've seen in non-metastatic CRPC and what we've accumulated over the time, I think there are 3 very effective AR pathway inhibitors. So there are obviously some patients where we would shy away from enzalutamide or apalutamide, if there are issues in terms of cognitive concerns, patients with history of seizures. But overall, I think there are 3 extremely effective agents that have performed very, very well. So it would be hard to say. We personally use a lot of apalutamide. The darolutamide for now in Canada is reserved only when we're going to give the triplet therapy. So this is an issue, and I think might be attractive if we can show that monotherapy works. And the enzalutamide has a long history, and we've had very good successes. So it's also a decision. Patients are interestingly interested in the different ones, and sometimes do their own research and come in and say, I'd like to get this one for X reasons. To say that I've got one that I think is clearly superior would be hard for me to say.
Dr. Shore, how do you think about this problem in your practice?
Yeah, well, we have the luxury of having access to doublet with Abi or Enza or APRA, and now arguably triplet with Daro. We will see doublet trials with Daro come forward and read out in early 2024, the ARASEC and ARANOTE trials. I think it goes back to, both the reviewing the specific interesting adverse events of interest, of course, the practicality of what's accessible, but all the trials, whether it was, Titan or Arches, Latitude, Arasens, Peace-1 are very effective. I'm a big proponent of triplet therapy in chemo-eligible patients who are high volume, absolutely. And for low volume, that's a shared decision-making conversation for that. I really want patients to have that opportunity to at least think about it.
Very good. So let's move on to the cases for this section. And again, I'd like to thank David Morris from Urology Associates of Nashville and Dr. Jason Hafron from Michigan Institute of Urology for providing these really great cases. I think they're going to bring out a number of interesting points, and we appreciate their collaboration in developing these cases. In general, which systemic therapy would you recommend for a 65-year-old patient presenting with de novo Gleason 8 prostate cancer and 3 asymptomatic bone metastases? You see the distribution of votes there. There's a great enthusiasm for intensification with only one outlying voter for ADT alone. Everyone else intensified by either addition of one of the 4 AR pathway inhibitors or a triplet therapy with docetaxel and darolutamide. Dr. Freedland, what would be your typical approach to a patient like this?
So, I think we first need to keep in mind that STAMPEDE data for patients with de novo oligometastatic disease actually showed a survival benefit for radiation to the prostate. So to your point earlier, Matthew, about local plus systemic, this is someone I would treat the prostate. As surgeons, we like to think if radiation works, surgery would work equally as well, though that's not formally been tested. So I'd certainly counsel him on local therapy of his choice. And then for the metastatic disease, he has metastatic disease. The data would certainly support intensification. And I think you get into the same issues of which drug do you prefer. And I think you can make an argument in multiple ways. I tend to use enzalutamide, but I think you could make an argument for multiple of them.
Dr. Saad, in the same patient who then goes on to have a PSMA PET CT scan that shows, say a dozen or so sites of metastatic disease to bone, does that information change your management? How do you incorporate that additional results of PET imaging in the management of patients in this disease state?
Sorry, you said me? Yeah.
Yeah, please.
Yeah, I'm still basing the data and my way of treating on conventional imaging based that the trials were based on conventional. And I think we need to work out what that translates to in PSMA. So I wouldn't shortchange that patient and say, no longer will I treat the prostate because PSMA upstaged him, and I would continue to insist on doing the maximum I can in terms of systemic therapy. I personally don't use abiraterone anymore because of the issues of metabolic issues that need to be followed, even though they're hormone sensitive and doing very well.
Very good. Let's go on to the next case. In general, which systemic therapy would you recommend for a 65-year-old patient with de novo Gleason 8 prostate cancer with multiple bone and liver metastases? In here, you see the voting is a little bit different. There's a lot more interest in adding docetaxel, with the majority looking at ADT docetaxel and a secondary hormone therapy. I hope that means darolutamide or abiraterone, where we have evidence from Peace-1 and Arasens. There was also a few votes for ADT and docetaxel with no AR pathway inhibitor. Dr. Beltran, could you support that preference for systemic therapy, and then if not, are there other patients in whom you would forego treatment with an AR pathway inhibitor?
No, I would, as long as an AR pathway inhibitor is available, I would add an AR pathway inhibitor in all situations of metastatic disease, and I would intensify with triplet therapy in this patient if the patient was chemo eligible. I think in certain parts of the world where potent AR therapy is not available, I think ADT docetaxel could be reasonable for some patients with metastatic disease.
Dr. Shore?
Yeah, I agree. I think that for this patient, let's assume he's a ECOG 0, your first shot tends to be your best shot. Hit the disease hard. I really like the idea that you're having 3 distinct novel mechanisms of action, the ADT, the docetaxel, and the darolutamide or the AR pathway inhibitor. And just as a side note on that last case, whoever picked the monotherapy ADT for mHSPC, it's just no longer a standard of care. But having said that, we still see in the United States where almost 50% of patients with mHSPC in 2023 are still getting monotherapy ADT. So there's an educational disconnect, and we really have to overcome that.
Yeah, I think you're absolutely right. And if it's perhaps the most important takeaway from this module is really the intensification is the standard of care, and intensification means addition of an AR pathway inhibitor. While a patient like this with liver metastases, there's concerns that he may be less responsive to AR inhibition. There is an established role for adding an AR pathway inhibitor. So while that may prioritize the addition of chemotherapy, that should not be at the cost of including an AR pathway inhibitor as part of the intensification. So next case, for a patient with metastatic castration-sensitive prostate cancer for whom you've elected to use a novel anti-androgen therapy without docetaxel, do you have a preferred agent? It's kind of similar to an earlier question we raised. So, Dr. Beltran, how do you think? Do you have a preferred agent? And if not, how do you think about this in your practice?
I think any of the approved agents are reasonable in this situation, and I agree with my colleagues. It all depends on sort of access and drug costs and side effects and monitoring, and I think any of these are reasonable, and I've used any of these in that situation.
Very good. This is a next case, 79-year-old patient with high volume metastatic CSPC. His pretreatment PSA is 173. CT and bone scan show widespread bone metastasis involving skull, thoracic spine, proximal humerus ribs, sternum, and lumbar spine. Regulatory and reimbursement issues aside, what would be your most likely treatment recommendation? And you see the most common response was triplet therapy with ADT, darolutamide, and docetaxel. Dr. Saad, how do you think about triplet therapy in a 79-year-old man with high volume de novo metastatic prostate cancer?
You might think I'm crazy because I'm a urologist doing chemotherapy, but I've treated patients that are above 85 on a regular basis. So I don't have an issue in patients who need chemotherapy to give it as long as they're well and accept that there are going to be issues. So I would have this discussion with this 79-year-old man who has clearly aggressive disease, and I wouldn't dissuade him from getting docetaxel. I would actually encourage him, but with the shared decision that there might be issues. And docetaxel is there's not a signed contract. You can give the first cycle, the second, third, and pull back if the patient is running into issues. So this is not a contract that it's 0 or 6, and we see them every 3 weeks with each dose. So definitely it would be an option for this patient.
Yeah, certainly not an uncommon scenario, right? Prostate cancer is the steepest age-related incidence of any malignancy. So these are often elderly patients. And in addition to the point you raised, which is you always have the option of discontinuing treatment, we would very comfortably dose reduce a patient, at least for the first cycle in this age group or older, as a strategy to improve the tolerability of that regimen.
And he's in his best shape now. After failing NHT, the response rate is so much lower, and he's going to be that much older and maybe unlikely to be able to get something that might actually make a difference.
Okay, last case I think in this section. This is now an 84-year-old man who has recurrent metastatic prostate cancer some years after a prostatectomy. Imaging shows bone metastases, described as extensive. Regulatory and reimbursement issues aside, what would be your most likely treatment recommendation? You see a distribution of choices here. They still have that one lone holdout with ADT alone. I'll refer to Dr. Shore's earlier comments about that choice, but otherwise consensus about intensification, but of different forms. Dr. Freedland, could you just quickly comment on your thoughts here? How would you approach this patient?
Yeah, I mean, I think it's chemo, I think in the right selected patients can, as we just talked about, being gingerly given to older patients. So you have to assess his overall fitness, frailty, a lot of different assessments. But assuming he's chemo fit, that has been shown to have the best survival benefit. So that would probably, I would favor the triplet. I think you could also make an argument he's took 11 years to develop metastatic disease, which is perhaps a little bit slower case, and that he might do very well with a doublet, especially at 84.
Yeah, I agree. I think the fact that he has recurrent metastatic disease many years after his prostatectomy and some of the volume of disease reflects his loss to follow-up. I would consider chemotherapy in older individuals, but not in this setting. I wouldn't agree to treat this patient with chemotherapy. Certainly, I would specify not on a virtual visit. And I think as one of the things we saw during the pandemic, some less than optimal care of decisions being made without actually seeing the patient in person. And I'm sure all the clinicians in the audience are familiar with how different a patient can look on a well-staged Zoom call and how they look in person at times. So our next presentation is by Dr. Saad. Fred, take it away.
Thanks, Matthew. So I was tasked in 8 minutes to summarize a pretty vast topic, but really just to set the stage, these patients that are metastatic hormone sensitive will progress to mCRPC, which is the lethal state of prostate cancer, and eventually the highest likelihood of actually dying of prostate cancer rather than with prostate cancer. And when we do ADT alone, and this is probably the main take-home message that we've been repeating, if you do ADT alone in an all-comer population of metastatic hormone sensitive, you can expect them, and this has been shown repeatedly, to become castration resistant within a year. So they don't fail in 2 or 3 years. The median is less than a year in almost every trial, and they will only live about 3.5 years if you start with ADT, even though you have effective therapies in mCRPC. So we can do better, and this was talked about, that local control does make a difference in some patients, and there are trials that have shown with the STAMPEDE that if you had less than 4 bone metastases, you significantly improve failure-free survival. And what does that mean? It means you delay castration resistance by treating the prostate. In itself, that's amazing. Treating the prostate delays castration resistance and turns out to significantly improve overall survival in the range of our systemic therapies. So to exclude local therapy in a patient that has low volume disease on conventional imaging, I still don't know how many METs on PSMA I would exclude a patient. The role of systemic therapy, clearly there's an established role. Chemotherapy alone with ADT significantly improves survival in patients with high volume disease. Really didn't look like it was helping patients with low volume. Not to say that it doesn't help, but you've got a lot of opportunity to catch up with subsequent therapies. In Latitude, abiraterone in high-risk patients significantly improves overall survival. But again, I highlight, these high-risk patients will become castration resistant in 7.5 months. So there is no reason to start ADT alone. And why I said recently that I didn't appreciate abiraterone compared to the other 3 AR-specific inhibitors is that you still need to follow these patients. It's not because they do well and are going to live longer that you can ignore the fact that they're on abiraterone. There is hepatic toxicity, but more important, hypokalemia, hypertension that almost quadruples when you lower from 10 milligrams to 5 milligrams. To say that you don't follow these patients might lead you to have significant issues. And so for a lot of reasons, I have excluded now, unless there's a contraindication to the 3 others, of using abiraterone in hormone-sensitive disease. Enzamet showed significant improvements in progression-free survival and overall survival in an all-comer population. And when you look below, you see that the hazard ratios actually in the low volume setting is actually even more beneficial, trending in the EMBARK and all the other studies that are showing the earlier you start, the bigger bang that you get for your investment. ARCH has confirmed again that enzalutamide delays progression-free survival and improves overall survival significantly. And again, the low volume disease has at least as much benefit, if not more, than the high volume. Apalutamide continued to confirm that an all-comer population will benefit. And again, whether you're high or low volume, and these patients, even though they were allowed to cross over, had significant improvements in overall survival. And then for us as urologists and for patients, PSA response is extremely important. And you see that the PSA responses are consistently better when you add an AR pathway inhibitor compared to getting ADT alone. And what's most important, and is becoming more and more our main objective as an early signal that we're doing the right thing, is getting to below 0.2. And there you almost triple the likelihood of getting to undetectable PSA by adding the AR pathway inhibitor, and this leads to significantly better outcomes, whether it's in time to mCRPC, time to radiographic progression, and there's an 83% reduction in the risk of death in patients that reach that 0.2 compared to patients that don't. And so really this is what you need to be looking at in the early start of these therapies. Then the question is, as was mentioned, we have AR pathway, we have chemotherapy. We've always had to choose one or the other. And so combining the two together to have the best biological attack to the cancer makes biological sense. And we have trials now that have shown in piece 1 that adding abiraterone to docetaxel significantly improves the outcome of patients compared to ADT and docetaxel alone. And this was most pronounced in the high volume patients. The low volume haven't reached the median survivals yet. So it's still a little early to say it doesn't help at all, but clearly the high volume patients. ARASENS was the first study to prospectively evaluate the triplet regimen compared to the doublet regimen. And again, the doublet regimen here is docetaxel plus ADT, since that was the standard of care when the study was designed. CHARTED had come out. Latitude, the ARPI studies hadn't already reported, and so the very best standard of care was the control arm. And as you notice, the only endpoint that really counted was overall survival. There was not an RPFS endpoint to insist on keeping patients on trial when they're starting to progress. Investigators were allowed to give very early subsequent therapy if patients progressed. And this is important because some studies insisted until RPFS and didn't allow you to get other subsequent therapies. So overall survival with the triplet upfront compared to the doublet of ADT and docetaxel showed a 32% reduction in the risk of death. And recently at ASCO GU, it was reported and published that whether you were high risk or low risk, you seem to be getting a benefit. And the low risk patient with the addition of ARPI is probably the reason they're getting so much benefit with the addition of over docetaxel. You see the time to CRPC, again, confirming that these patients progress very quickly to CRPC and to first subsequent therapy, but even though they got very early subsequent therapy, that overall survival was reached very significantly. And again, that holy grail of getting to undetectable PSA was achieved much more effectively with the triplet therapy by adding darolutamide to docetaxel. And you see that docetaxel and ADT alone didn't reach much more than about a 25% of patients reaching that goal. And why is that important? Getting to the under 0.2 led to a significant overall survival benefit, whether you looked at 6 months or at 9 months, the time to that PSA undetectable level. So clearly, the patients who don't get to 0.2 is our next challenge. What do we do in the patients that don't get to 0.2? Is there a strategy of more intensification? And what do we do to the patients who stay under 0.2 for a long amount of time? So the future and more questions, since research is continuing, is that patients with mCRPC are at very high risk of rapid progression and early death. Treatment beyond ADT is recommended in all patients. You have to justify why you wouldn't do it. adding an NHT must be considered in patients who receive ADT and docetaxel. That is the level 1 evidence from ARASENS. Further intensification in some trials are ongoing, the role of PARP, radioligand, immunotherapy, but de-intensification needs to be studied to try to pull back in some patients that have extraordinary good results. And just to encourage the multi-D approach, unfortunately, it's no longer an era where urologists can do everything all alone in their own little setting. Thank you.
Thank you, Dr. Saad. So this week, the Oncology Drug Advisory Committee of the FDA recommended, by a vote of 11-1, the approval of olaparib plus abiraterone and prednisone as first-line treatment for patients with mCRPC and a BRCA mutation. Further, they specifically recommended the FDA restrict use of that combination outside of that specific molecular setting. So what do you think of that decision, Dr. Beltran? Do you agree with that recommendation, and why?
Well, I do think that BRCA-mutated tumors are the patients that respond the best to PARP inhibitors, and they're the people that respond the best to combination therapy. And are there patients that don't have BRCA mutations that might respond, or who are unavailable in the trial? I do think that, but I think it's our job to figure out who those patients are, because there are toxicities with combination therapy. So I think that the story is not over, and that this is, the first step is to get the approval for the patients we know that are going to benefit the most. And now it's really our job to figure out who are those other patients and what's the best way to test and do better to find those patients that might benefit from the combo. So I do think that the biology of BRCA is there's other variants within that same HRD, and there's other biology with the crosstalk that we need to figure out better.
Yeah, I appreciate that perspective. And the other point, to your point, is that we're not depriving patients who have other mutations, DNA repair mutations, the opportunity to be treated with olaparib. It's just this combination as part of first-line treatment. So I guess the message in there is, the results from earlier approvals stand, and so patients could receive olaparib monotherapy who have other alterations. The other point I think we should add, we sincerely hope that the population actually studied in this trial will decline over time, because really all of these patients, most or all of these patients, should be receiving an AR pathway inhibitor as part of initial systemic treatment for metastatic disease. So this idea that there'd be patients receiving abiraterone or another AR pathway inhibitor for the first time when they have mCRPC should be declining as we move forward. Let's go on to a few cases. This is a 65-year-old man receiving ADT for M0 disease after radical prostatectomy, found to have asymptomatic bone metastasis. Genetic testing is negative for homologous recombination repair mutations. Regulatory and reimbursement issues aside, which systemic treatment would you most likely recommend? So mHSPC, biomarker negative testing for DNA repair mutations. Here there's some additional choices provided, including Sipuleucel-T. Dr. Freedland, is there still a place for CYP-T in managing patients with metastatic prostate cancer? And if so, is this the right setting?
Yeah, no, I think there is a role, and I think this is the right patient. He was on ADT and developed metastasis while on ADT, so he has mCRPC. No homologous recombination repair mutations, so you wouldn't necessarily think about certainly PARP monotherapy. So standard would be Abi or Enza typically, but Sipuleucel-T, he's asymptomatic. 65 is increasingly young in our patient population. And we have randomized trial data showing overall survival benefits. So I think it's a great treatment. We know it doesn't delay progression-free survival, so it's not going to buy us tons of time, but gives him some time to contemplate and understand that he has metastatic disease, and then a few months later you start Abi or Enza. For me, it'd be more Enza because I'm with Fred. I'm concerned the metabolic issues with Abi, but I think it's a great first-line mCRPC for asymptomatic patients.
And just a quick follow-up question. How would you sequence AR pathway inhibition in a patient like this who has not received the prior AR pathway inhibitor if you chose to use CYP-T? Would you do it concurrently, sequentially?
I would probably wait. There's not data for concurrent. Certainly if you're thinking Abby with the prednisone being immunosuppressive, there's data that doesn't really suppress the immune response to CRPC, but ultimately we don't know. That's based on biological markers. So I would give the CRPC first, you wait a few months, and then start AR targeted. Again, in my practice would be ENZA.
It certainly is a common theme in managing our patients. We have remarkably limited information about optimal sequencing, so we have many available tools in our toolbox. We often don't know the optimal sequence in which to use them. So we should celebrate when we do know the differences and make the best of those opportunities. So this is our next case, 65-year-old man receiving ADT for M0 disease. A little bit different here. He has widespread, moderately symptomatic bone metastasis. Genetic testing, again, is negative. Regulatory and reimbursement issues aside, which systemic treatment would you likely recommend? Docetaxel and secondary hormonal therapy. By that, I'll take that to mean an AR pathway inhibitor, radium-223, plus a AR pathway inhibitor, Abby or ENZA, or Abby and olaparib. Dr. Saad, so this is mCRPC, widespread bone metastases, moderately symptomatic, in someone who had not received a prior AR pathway inhibitor or chemotherapy. What would you recommend?
Yeah, I'm not sure if people understood the question because docetaxel, this triplet regimen is for mHSPC.
Yep.
We have not really studied it in mCRPC, so I think there might have been a confusion in understanding. So I think the choices here are docetaxel or an AR pathway inhibitor, and I think the worldwide consensus in first line mCRPC, unless they're severely symptomatic, viscerally metastatic, I think the majority would go with an AR pathway inhibitor and look very closely at how they're responding. And I think this is reasonable. This is a kind of patient, 65-year-old patient that I would have considered abiraterone olaparib if I had access to it. It says these patients in the study, 65-year-old, had a 50% reduction in the risk of radiographic progression and actually about a 35% reduction in the risk of death in those under 65, and they weren't all mutated. So there's something going on in these young, aggressive patients.
Yeah, I think you raise a good general point in that as well. There are times when we can generalize across different disease states. This is not one of them. And there may have been some misunderstanding by the respondents, but this is mCRPC. So I certainly wouldn't be applying PEACE-1 or Arisen's data to first-line mCRPC. We just don't have that evidence. And if you're going to use those agents, they would be sequentially, not in combination. I'd also further add that we have good evidence that, say, adding radium-223 to abiraterone results in net harm in this setting and should not be done. And if you're going to use radium-223 in an approved manner, you should also be doing so in combination with the bone protective agent to spare patients the unintended toxicity of fractures. So our next discussant is Dr. Shore. He's going to take on the topic of therapeutic considerations for patients with newly diagnosed metastatic CRPC. This is a challenging topic because of the complexity added by management of mHSPC. So take it away, Neal.
Thank you very much. So the overview is say, you can't boil the ocean on this one, so I'm just going to focus on the overview here. We'll talk about Sipuleucel-T. We'll talk about some of the biologic basis for PARP inhibitor combinations with either abiraterone or enzalutamide. We'll talk about the combination trials that have read out now, these key phase 3 trials, PROPEL, Magnitude, and TALAPRO-2. I'll try to restrict my commentary to these patients that did not have an HRR mutation. And I think in Matthew's presentation, he'll be focusing on the HRR positive patients for mutation. And then we'll touch base briefly on CDK4 and 6 inhibitors and some trials that are ongoing, known as Cyclone 1 and Cyclone 2. So, this is the schema of the IMPACT trial that back in 2010. And so what's interesting here is, Sipuleucel-T approved only in the United States for asymptomatic mCRPC patients, both with either bone, nodal, or visceral metastases, but as long as they're not symptomatic on opioids. This is an all-comers population. So we have pembrolizumab, which is approved and tumor agnostic, but only if you're MSI high, and this is an all-comers This was a successful trial, and ultimately it had level 1 evidence to put it into the guidelines in the United States. And here's the KM. What's really intriguing, you look at the Shellhammer data, as it's oftentimes called, is when you did this retrospective analysis, looking at by quartile data, the patients who had PSAs under 22 as opposed to over 130, albeit they all have beneficial effect, it's really rather marked if you start this therapy early. The quality aspect of starting Sipuleucel-T, it's over in 4 to 6 weeks, it's 3 infusions. The safety profile, remember when this first came out, people are like, oh, immunotherapy, this is new to us. This, we don't really get it. It's sort of not a gray box, but a black box. But what we realize now looking here, this is a exceptionally well-tolerated therapy. Additional trial was done, the Prostate, to confirm any lack of CV events, which was very nicely established. And that was an initial concern by the FDA. And here again, looking at the Prostate, this is over almost 2,000 patients prospectively receiving Sipuleucel-T. Look at the SAEs, the grade 3, 4s, and 5s. They're all, remarkably low, and almost all less than 1%. And so the overall survival, again, sort of recapitulating the Shellhammer data, looking at the lowest PSA levels, one sees if you're going to use this, you want to use it early in the course of the disease. And this, we have had phase 2 trials, phase 2, combining Sipuleucel-T with enzalutamide as well as with abiraterone. Probably mechanistically makes a little more sense to combine it with a non-steroid containing agent, but that's never really been shown that the 5 milligram BID has a negative impact on the immunotherapeutic benefit. Raina McKay did a very nice retrospective analysis looking at this consort diagram. May be hard for you to see, but the bottom line here from her study in this Medicare population, the top line results, is a 13.9-month survival OS difference with Sipuleucel-T versus starting it as a first line versus starting it with an androgen receptor pathway inhibitor. And you can see the additional complementary survival benefit starting it early on when Sipuleucel-T is used. It's very interesting. It is mostly used within the urologic community and some selected medical oncology practices, but there's an enormous amount of data that's been put out there in the last 13 years that it's been available in the US. So the phase 3 trials of combining a PARP inhibitor and an androgen receptor signaling inhibitor in the first-line setting, of course, we're always trying to combine novel mechanisms of action to get some additional synergy, and this really is the basis. The point of concept, or proof of concept, was known as Study A. I don't have time to show that, but very nicely presented at a podium presentation by Noel Clark, and I believe Fred was also the leader of that trial, which gave the concept that in an unselected population, a combination of olaparib and abiraterone bested abiraterone by itself with a comparator. So now we have published these 3 discrete trials that have clearly demonstrated the benefit of the combination, but Magnitude has only demonstrated the benefit of the combination in HRR mutated patients, not the wild type, but Propel and Talipro-2 have. Casper still has not read out. And here's the Propel trial led by Fred and Noel Clark. What's the rationale? I mentioned Study 8, but the concept here, and you can read through this, is essentially amplifying DNA damage repair by augmenting androgen receptor selectivity to DNA damage and also increasing activity of novel hormonal agents as well. So there's a synergy, arguably. This is very well demonstrated in preclinical models, and so we use this strategy now in Propel and Talipro-2, and arguably in Magnitude, which was a little bit of a different trial design. But here's the Propel trial design, and so 1-to-1 randomization. You can see the stratification factors that are listed there. This was the approved dose of olaparib as well as abiraterone, the approved agency dose. The primary endpoint, rPFS, secondary key endpoints you see listed here. The Kaplan-Meier demonstrates here that this was a clearly successful trial, meeting its primary endpoint with a hazard ratio of 0.66 and a p-value less than 0.0001 in an all-comers population. And so the curves separate, and stay separated. The survival benefit is still forthcoming, and with each successive analysis, the curves are separating further, but has not yet reached statistical significance. Now, the other key aspect here is the RPFS in the BICR versus the investigator assessment. Here you see a difference of about 11 months, and in the investigator, it's about 6 months. So the conclusions of PROPEL are listed here. Unfortunately, and frankly for me, very disappointingly, as Matthew alluded, the ODAC was voted against the all-comers population for the benefit, but voted for insisting upon tissue testing, which is actually contradictory to what the EMA voted, and now PROPEL within the EMA is now approved. It's also approved, the PROPEL data based upon these findings is approved in several other countries, notably Brazil. So the magnitude was also a very important study. It's a little bit of a different trial design. In the biomarker negative for the homologous recombinant repair pathway, there was a futility analysis, so what continued to go forward is only in the biomarker positive. So essentially the DDR, DNA damage repair pathway, you see the panel listed here, fairly comparable to the panel, but there are some notable differences as it relates to PROPEL as well as TALAPRO-2. But this ultimately was an unsuccessful trial in the biomarker negative. Some have argued that that's because of there was a dose reduction in the use of niraparib because of toxicity concerns, and there were some differences in the inclusion criteria, mainly in prior exposure to abiraterone about 4 months prior to baseline, as opposed to TALAPRO-2 or TP2 as it's oftentimes called, and PROPEL, which was a 12-month avoidance prior to baseline. So here's the TALAPRO-2. It was just recently presented at ASCO GU 2023 by Niraj Agrawal. Very similar design. There are some differences in the stratification factors. The HRR gene alteration status deficient, biomarker positive versus non-deficient or unknown, was prospectively acquired as opposed to in PROPEL where it was retrospectively acquired. But nonetheless, as I'm going to show you, even with that caveat, the results are almost absolutely comparable in terms of the RPFS in an all-comers population. You see, and the key thing in both PROPEL and TALAPRO-2 is it was an active comparator. Here, the active comparator was enzalutamide and placebo, and in PROPEL, it was abiraterone and placebo. It's very important to recognize, and yet there was an 8-month benefit at the median for the all-comers population. Again, another way of thinking about and reading the rationale for combining a PARP inhibitor with an AR pathway inhibitor. Essentially, it's the co-inhibition may be efficacious. There's very good preclinical data, and this was the basis for, as well as Study 8, and thus the basis for moving forward with this combination. What's remarkable is that there's just indisputable evidence if you're BRCA positive, the results are just breathtakingly significant. The challenge for some, even though they make up a small percentage, about 10% of the total population of the trial that was reviewed, roughly speaking for both TALAPRO-2 and for PROPEL, the aggregate population, there was still an RPFS benefit in both TALAPRO-2 and PROPEL in the HRR mutation and negative population. And here's the RPFS for the blinded independent central review in TALAPRO-2, also statistically significant with a hazard ratio of 0.63, comparable to the 0.66 that we saw in PROPEL. And again, this is another way of thinking about it and reviewing tissue testing. Just a quick word on tissue testing. Tissue testing for somatic aberrations, as well as ctDNA, the liquid biopsy, as well as germline testing, whether it was prospective or retrospective, was rigorously performed in these two trials. What's notable is that in the real world, testing, there's a paucity of testing. Less than 50% of academic centers we've published don't do routine testing for this patient population, and way under 30% within the community. And yet there was a subset analysis, subgroup of a subgroup by the FDA, which they looked at, which I think was very unfortunate. And thus, I feel strongly that their decision was very disappointing. The Cyclone one, I'm just shifting over right now to my request, was to look at CDK4/6. CDK4/6 is approved in breast cancer patients. I don't treat breast cancer patients, but now it's being looked at, and here's some of the data, looking at abemaciclib or abema in monotherapy, and one can see response rates. Why the rationale? Kind of similar in the notion of combining two different mechanisms of action that we saw in PROPEL, TALAPRO-2, and MAGNITUDE. Now we're thinking of how can you combine a targeted different therapy with abiraterone. It's described here. The hypothesis at the end of the day is that the dual inhibition of the AR axis and cell cycle, this really works on the mitotic spindle, the area, what's known as the CDK4 and 6 cyclin D1 axis. It's a very unique, interesting, targeted mechanism of action. And here is an ongoing trial. I believe, Matthew, you are leading this trial. And so I think this is really interesting and could potentially add another proverbial tool to our toolbox. And we await the readout of this very important trial. Thank you.
Thank you, Dr. Shore. You raised a really interesting point, and that is sort of the ODAC decision about PROPEL and the difference with that in the European decision about based on the same evidence. So, Dr. Saad, you were a principal investigator of PROPEL. What are your thoughts about the ODAC decision, and how do you envision?
I'm obviously very disappointed because the reality that Neal mentioned is that a lot of patients are walking around and we don't know their status. And as much as we'd like to know it, sometimes we just can't. So I was very happy with the European decision to allow the physician to make the decision. And from my understanding, it's not because they allow it that everybody's getting it. And it's a little bit like the triplet therapy. You're not restricted to saying you have to have liver metastases to be able to get triplet therapy. You're looking at your patients as a whole and deciding that this patient might not do as well with the standard of care NHT. And with the 7.4-month improvement in overall survival in the ITT, I think it was very compelling. And it's unfortunate that they're limiting it to the patients that are going to get most of the benefit, but don't allow us to consider it in patients that we either don't know or might be negative, but with other very high-risk features.
I appreciate that perspective. Dr. Beltran, what's the optimal timing of PARP inhibition in a patient with a germline BRCA mutation, BRCA2, I'll specify mutation?
I don't think we know the optimal timing. I mean, it's approved for mCRPC post-AR pathway, now potentially in combination with an AR pathway inhibitor. Whether or not it's going to have benefit in earlier stages, I think we'll see the trials in the hormone-sensitive stage. In breast cancer with BRCA germline mutations, it's approved in the adjuvant setting. It would be great to do those types of trials in prostate cancer. Germline mutation carriers are a minority. I mean, we see somatic much more frequently, but it does represent a very special population with poor prognosis, and so it's likely we'll see an evolution of the optimal timing of this in the future as well.
Thank you. We got a number of really interesting questions from the audience. I'll try to take on one or two of these as time permits, but we talked about the role of treating the primary tumor in patients with low-volume de novo metastatic disease. But where do you start and stop with radiating the metastases? Dr. Freedland, how do you think about that issue?
Yeah, it's a great question because I think we all want to do it for oligometastatic disease, but we can't necessarily all agree on the definition of oligometastatic disease. So I think it's obviously very crucial in terms of multi-D discussions, and I mean, the metastasis-directed therapy is given by the radiation oncologist, so certainly bringing them into the loop in the discussion making. I think 1, 2, 3 metastasis, absolutely. As you get to 4, I think we get a little bit more nervous. 5 and 6, harder to, a little bit harder to justify in that sense. And I think one of the questions that we're facing now is, and to Fred's point, conventional versus PSMA. If someone has a sole spot on conventional imaging, you'd say, great, metastasis-directed therapy, we'll treat the prostate, et cetera. We think we know what to do, and all of a sudden he gets a PSMA and it's everywhere. Are you going to treat it like low volume? That's what Stampede said, still, take out the prostate or irradiate the prostate. Are we going to do that in this case? Does it need chemotherapy? So all of a sudden high volume, I would argue no, but I've certainly heard in our tumor boards of people arguing yes. So I think we need to reevaluate in the PSMA era, but I think certainly for 1, 2, 3 Mets, yes to MDT.
Yeah, I think the other point to be made, I think, is that there's no going back from PSMA PET-CT, right? It's widely used, and we talk about these issues almost in isolation, like conventional imaging and PSMA PET imaging. But going forward, we're not typically doing sequential imaging in patients, and there is a interesting observation that the radiologists get a lot better at finding metastases on conventional image CT part of the scan after they see the nuclear medicine part of the test. So we're just going to lose some of the prior definitions by conventional imaging as a consequence of introduction of that really disruptive technology. Got one more question from the audience before we move on to some great cases, and that is, what is the role of carboplatin in either MHSPC? Dr. Beltran, are there patients you would use carboplatin in MHSPC?
I use carboplatin in situations where I see small cell neuroendocrine differentiation in combination with ADT, AR pathway inhibitor, and even potentially think about docetaxel carbo such situations. I think the AR path, it's complicated, I think, in that situation, but there may be, some situations where you might consider that. Otherwise, in the later stages of prostate cancer, thinking about a cabazitaxel carboplatin regimen for patients that have very aggressive features or small cell neuroendocrine features.
Yeah. And I think I'd add that in the interest of time, we won't go into that because it is complex. There's a whole variety of issues that you would look at. You certainly know very well the issues of how to think about neuroendocrine differentiation, and it includes not just pathology, but other
and also, I guess, in the breast, the DNA repair aberration situation too.
Yeah, that's a story we need a lot more evidence on as well. So we'll go on to some cases. In general, what is the optimal approach to mutation testing for possible use of a PARP inhibitor in mCRPC? Dr. Shore, you commented on the range of testing that's available, and you see the choices here. The most common answer was really comprehensive germline and somatic testing. Is that the approach you recommend?
Yeah, I completely agree with that. So yeah, if a patient hasn't received any testing, you can certainly go this route. One could argue that, well, maybe you don't need to do a germline if indeed their somatic is positive, but you'd certainly want to know the germline to inform their family. So what oftentimes called cascade family testing, and inform them about their risk for malignancy. So I think this is really important. But I think, as Fred said earlier, a germline's easy. It's a blood test or a buccal swab, saliva, and it's fairly inexpensive by U.S. standards. Oftentimes, patients, if they've had a previous prostatectomy, you can't get the specimen or it hasn't been properly preserved. And if a patient is largely mCRPC with lots of bone lesions, they're not always easily biopsied by your interventional radiology team. So then you have to go with liquid-based testing. And the ctDNA testing can be faulty if you don't have adequate tumor cell shedding. So in my experience, and what I do for my metastatic patients is I get the somatic testing when they come in metastatic. I germline test all patients. NCCN says everybody except grade group 1 and 2 if they don't have a family history. Half of the patients you talk to don't know their family history. So I believe that germline testing should be universalized and democratized for anybody with prostate cancer.
I appreciate that, yeah. So regulatory and reimbursement issues aside, for patients with mCRPC and germline BRCA2 mutation who you're planning to administer a PARP inhibitor, do you have a preference for which one? Dr. Freedland.
Yeah, I mean, Up until recently, the data were certainly much stronger in terms of olaparib. We had phase 3 trial data. Rucaparib was approved based upon objective response rates. We recently saw at GU ASCO, overall survival benefit relative to chemotherapy. I thought that was relatively impressive data. I think there's currently some issues in terms of company and supply and whatnot. I think there's a familiarity with olaparib that would probably drive preference to that. But as rucaparib and niraparib is moving forward, not yet in this space, but talazoparib, I think in the future, we will probably have a lot of choices, particularly earlier. But I think in this space, at this point, I think the data are strongest and most robust with olaparib.
Yeah. Dr. Saad, do we need more than one PARP inhibitor in prostate cancer?
Do we need more than one? I think we have to have as many choices as possible. I think limiting choices is going to be an issue, and there are patients that are going to possibly tolerate. We have never done head-to-head studies, at least not in prostate. And so I think until we have head-to-head studies, it's like saying, should we limit it to one pathway inhibitor? I would be very disappointed if we were stuck to just one.
Yeah, I think it's a valuable perspective, kind of analogous to the issue we confront with 4AR pathway inhibitors, right? You could maybe do with fewer, but we're glad to have them all, and there are specific patients who we're going to have a strong preference for one over the other based on safety and in some cases strength of evidence. In general, when administering a PARP inhibitor to a patient with metastatic prostate cancer, do you use prophylactic, antiemetic, or GI medications? What are your thoughts, Dr. Beltran?
I don't usually use it prophylactically, but it does become an issue, and so in those situations, I do add it. I follow them really closely in the beginning.
And Dr. Short, recognizing these are important issues for some patients on these medications, do you use prophylactic treatment to address potential GI?
No, I don't.
Yeah.
I don't. If you're going to see the GI side, the toxicities, which they tend to be mild to moderate, they're not overwhelming. It's early on. I think I'm more aware of querying patients. Sometimes patients won't even bring them up. Maybe they're having some change in, baseline mild nausea. But I do not prophylactically treat. I have not had the need to do that, whether it's with olaparib or rucaparib.
Very good. So now we have a case. 67-year-old man presents with Gleason 5+4 prostate cancer, PSA is 12. CT and bone scan shows spine and pelvic lesions and small positive lymph nodes in the pelvis. Germline testing is negative, but somatic testing from a biopsy reveals a BRCA1 mutation. Of interest is family history, includes a mother with breast cancer. Regulatory and reimbursement issues aside, what would be your most likely treatment recommendation for this patient? So this is mHSPC, BRCA1 positive. Dr. Freedland.
So, I would say it's certainly quite tempting to think about putting a PARP inhibitor into the mix. Just he has BRCA1. We tend to think more BRCA2, but it's likely at some point in his journey he's going to get a PARP inhibitor, and everything we're learning is if you're going to get a drug, using it earlier is better. That being said, there's no data to support its current use in mCRPC. So I think we go where the data are, and we can debate whether he's high volume or low volume, number of METs. He's, Gleason 9, probably more on the high volume, so I'd probably lean towards a triplet. But, it's tempting to want to put that PARP. I want that data. We just don't have that data yet.
Yeah, agreed. Dr. Beltran, would you treat this patient with a PARP inhibitor in this setting?
No, we have, I agree with the comments. We have data for the triplet, or in the situation I probably would consider triplet. They do have a poor prognosis, patients with germline BRCA mutations, but there's no evidence to say that they won't benefit from our standard of care drugs. So we should treat them with standard of care, and I think that this patient would likely respond very well next line to a PARP inhibitor.
Yeah. And Dr. Short, would the observation that he has a somatic BRCA mutation impact your thinking about the role of docetaxel if you're choosing between doublet and triplet therapy in mHSPC?
If I'm hearing you correctly, is if the patient has a positive somatic mutation, Does that influence my decision to do doublet?
Yeah, so
or
how would
triplet?
you treat this patient? And is the presence of a BRCA mutation
Oh, I would
increase your enthusiasm for adding docetaxel?
Yeah, I would treat this patient with triplet therapy, and I would share with the patient that, it's clearly very important that he's BRCA, and that the moment he converted biologically to resistant disease, that would be my most like next therapy.
Yeah, I agree. I would take the same approach. I think we have one more case. A 72-year-old man presented with Gleason 4+4 disease. 2 years ago, CT and bone scan were negative. He had proton beam radiation therapy with 2 years of ADT. His PSA nadir was 0.1 and then rose shortly thereafter to 11. Subsequent imaging shows uptake in a lung nodule, retroperitoneal node, and sclerosis in bones, although the bone scan is negative. He has a BRCA2 germline mutation. Family history is negative for other cancers. Regulatory and reimbursement issues aside, which systemic treatment would you most likely recommend? Dr. Saad?
I think here the question, the answer, this is first-line mCRPC with a BRCA mutation, BRCA2. This should be a no-brainer. This patient needs a PARP inhibitor in combination with an AR pathway inhibitor, and in the case of PROPEL, it would be abiraterone and olaparib, because this patient is going to progress extremely rapidly. The time to progression in these patients of PSA progression was less than 6 months, 8 months for rPFS, and when we introduced this therapy, the survival is tremendously better. We had a hazard ratio of 0.29 for survival compared to abiraterone alone.
In the BRCA?
In the BRCA mutated patient. So this is absolutely necessary, and this goes back to even the profound data that the earlier you introduce it, the more chance you have of avoiding further resistant mechanisms of coming in.
Yeah, I agree with your perspective, and this really provides like kind of an outstanding example of a good setting for which to use that, now and soon to be approved setting to use that. These are patients who should receive a PARP inhibitor at some point in their care, and so the threshold to include it in combination with abiraterone, I think, should be quite low, given the survival benefit that was observed in PROPEL, and you nicely commented on here this evening. So we'll go on to my presentation. I have the task of discussing the management of mCRPC in patients with HRR gene alterations. Some of this has been very nicely covered by Dr. Shore, and so I'll just briefly comment on the sections of overlap as a method of reinforcement. We talked a little bit about the importance of testing, and it's notable that these are common findings. These are not rare events in prostate cancer. The frequency of DNA repair gene alterations increases in patients with metastatic disease versus localized disease. And about 20 to 25% of patients with metastatic castration-resistant prostate cancer have identifiable pathogenic mutations in a DNA repair gene. That's a high enough rate that we should routinely be doing testing, and those mutations, as we've heard, are quite actionable. About half of the mutations that are found are germline mutations. It's this beautiful data on the right from Pritchard that really is a landmark study showing an unexpectedly high rate of DNA repair mutations in patients with metastatic prostate cancer. This was family history of prostate cancer did not seem to be predictive. And as Dr. Shore pointed out, we often don't have a detailed family history of our patients, so really need the importance of doing testing. The most commonly altered genes, germline genes, are BRCA2, BRCA1, CHEK2, and ATM. These are the NCCN guidelines for testing. A lot of words there, but I'll try to make it very simple. Germline testing is recommended for patients with a personal history of prostate cancer who have metastatic disease, regional risk disease, very high risk disease, or high risk localized disease. Also patients with any personal history of both prostate cancer and breast cancer. Personal history of prostate cancer with a strong family history of cancers associated with DNA repair, and that's that long list on the left side. And then there should be consideration of germline genetic testing for patients with intermediate risk disease who also have intraductal or cribriform histology, as those are associated with a higher proportion of inherited DNA repair deficiency. Somatic testing also has an important role, recognizing if you only do germline testing, you'd only find about half of the mutations. It's recommended for patients with metastatic prostate cancer, as well as selected patients with regional node positive disease. NCCN also notes that in doing that testing, you should include testing for mismatch repair deficiency to find the 1% to 3% of patients who may be candidates for treatment with pembrolizumab. PARP plays an important role in single-strand break repair, and PARP inhibitors induce synthetic lethality for patients with homologous recombination repair deficiency. There's PARP inhibitors, 4 commercially available PARP inhibitors: olaparib, talazoparib, niraparib, and rucaparib. Differences and similarities between them are shown here. There's some differences in their potency of inhibiting PARP1 and PARP2, and differences in trapping, although the latter, the clinical significance of the latter finding is not yet fully established. This is a summary of the PARP inhibitor monotherapy trials in mCRPC that really have established the importance of PARP inhibitors in metastatic castration-resistant prostate cancer. These studies looked at patients with mCRPC and disease progression despite a prior AR pathway inhibitor and at least one taxane-based regimen. TOPARP was the first study that looked at more or less all comers and observed that presence of a DNA repair mutation was a strong predictor of activity. All of the subsequent phase 2 studies listed here looked at molecularly selected patients, although it's worth noting they use somewhat different definitions or different methods of identifying eligible subjects. Consistent, very substantial rates of response across the different studies, varying from about 30 to more than 50% objective response rates with PARP inhibition in this very treatment refractory patient population. And the results of these trials have led to pivotal studies of PARP monotherapy in mCRPC. This is the design of the very important and landmark PROfound study. PROfound enrolled patients into 2 different cohorts: cohort A, BRCA1, 2, and ATM mutations, and then cohort B of patients with other DNA repair mutations. Patients in both cohorts were randomized to olaparib or physician's choice. And as all of you are likely very familiar, this was a very positive study showing marked improvement in rPFS in the overall population of cohorts A and B, as well as an improvement in overall survival. There are differences across different genes. This is a gene-by-gene analysis of PROfound, looking at rPFS on the left and OS on the right. Among the more commonly altered genes, BRCA2 is a big driver of response as measured by both rPFS and OS. And the results of this study led to the FDA full approval of olaparib for treatment of patients with deleterious or suspected germline or somatic HRR gene mutations who have progressed following prior treatment with enzalutamide or abiraterone. This is a summary of the rucaparib drug development plan. It includes 2 trials, Triton-2 and Triton-3. Triton-2 was in patients who were highly treatment refractory, single-arm study, and then Triton-3 was a randomized controlled trial looking at patients who had progressed on a prior AR pathway inhibitor. These are the results of Triton-2, showing a high objective response rate in the enrolled patients. Overall response rate, CR plus PR, was about 45% in these patients. And the results of that study led to the FDA approval of rucaparib in 2020. Triton-3 is a randomized controlled trial that took patients who had failed an AR pathway inhibitor, mCRPC, rucaparib versus physician's choice. This study stands out in that it included really an active comparator, so physician's choice here wasn't just the AR pathway inhibitor switch, but also docetaxel, and about half the patients in the study received docetaxel as physician's choice. Rucaparib was associated with a significant improvement in rPFS, as well as and that was notable in that the improvement was seen in versus both docetaxel and an AR pathway inhibitor. So this study is important, and it gives us information about sequencing and argues that patients with BRCA mutation should receive a PARP inhibitor prior to docetaxel based on the improvement in clinical outcomes. Dr. Shore has nicely summarized the results of the PARP-based combination therapy, so I'll just be very brief here in going over this again. PROPEL looked at abiraterone plus or minus olaparib, really in an all-comers population, showed an improvement in radiographic progression-free survival and consistency of outcome across subgroups. The greatest treatment effect was seen in patients who were so-called biomarker positive, and the largest effect was seen in patients with BRCA mutations, explaining the FDA decision, although we've discussed the controversies about that. Magnitude had a somewhat different study design. It enrolled into different cohorts. It's almost like two parallel phase 3 studies, biomarker positive and biomarker negative. Biomarker negative patient population was discontinued early due to futility, and then the biomarker positive study went on to complete accrual and analysis. In Magnitude, the addition of niraparib to abiraterone acetate improved rPFS in the biomarker positive cohort, with the majority of the benefits seen in the BRCA1/2 mutated group. We've heard about TALAPRO-2 as well, another very important study. In this case, looking at a different partner. This is talazoparib plus enzalutamide, and I think going forward that will be a consideration depending on the individual patient, whether your preference for sort of background AR pathway inhibitor is abiraterone or enzalutamide. As you've already heard, there's an improvement in rPFS in the overall study population, with the largest benefit seen in the HRR mutated subjects in the trial. In summary, germline and somatic DNA repair mutations are common in metastatic prostate cancer, and we should routinely be doing both germline and somatic testing in appropriate patients. Olaparib is approved in HRR mutated mCRPC. Rucaparib is approved in BRCA1/2 mutated mCRPC. PROPEL has shown improved overall survival, it's improved radiographic progression-free survival in all comers. And as we discussed the recent ODAC recommendation for approval in BRCA1/2 mutated patients. The benefit of niraparib was seen only in HRR mutant patients, particularly in BRCA1/2, and talazoparib has shown benefit similar to that seen in PROPEL, in this case, in combination with enzalutamide. There is active ongoing investigation looking at PARP inhibitor combinations in mHSPC. So now we'll go on to the last section of tonight's presentation, and we'll begin with a few questions in the last couple of cases. So what should be used first for patients with bone-only metastasis in PSMA-positive disease? So mCRPC, you're making a choice between radiopharmaceuticals. Should it be radium-223 or should it be lutetium PSMA? Dr. Shore, you have a lot of experience with both of these agents. What are your thoughts?
So this would be in first line?
So mCRPC will specify for discussion that they've already received an AR pathway inhibitor and docetaxel.
And docetaxel,
Yep.
okay. So then, so there's FDA approval based on the VISION trial for lutetium, PSMA RLT, and there's also, based upon the VISION trial, and Alsimca, you can give a radium-223 prior or after docetaxel. I think that for the data that is right now, if I had to pick one, if that's the question.
Which one first? Yep.
I would probably go with lutetium first. But right now there's a challenge because there's a shortage. There's been supply issues. If for some reason I couldn't get access to it, then I would be very comfortable in going with radium.
Dr. Saad, thank you. Dr. Saad, or Dr. Freedland, you nicely raised your hand. Supply issues aside, which would you prefer, lutetium, PSMA, or radium-223 in a patient like that described?
I just want to make a quick comment that we have randomized from the Therapeutic trial. I know it's not exactly your question. but they were selected to be PSMA enriched. We have randomized trial data of lutetium versus cabazitaxel, which would be second-line chemotherapy, showing no difference in overall survival. So we certainly saw an RPFS benefit for lutetium there. So I think we just need to keep that in mind as another option. But I would refer to someone like Misha or Fred. For actual manager, I just want to make sure that's on the table.
Thank you for that. It is important. Those aren't the only two choices. There are other choices.
Right.
And it is one of the challenges that I alluded to earlier is we often don't have information about optimal sequencing, candidly, because usually these pivotal studies choose the weakest comparator that they can design their trials with. And so we often don't know what the comparison against an active drug would be, and therapy is important in that regard. So, Dr. Saad, what do you think?
You know, you clearly specified that this is bone-only disease. There's no visceral metastatic disease, which would likely change. But in most patients right now, if we have access to lutetium, we would go with lutetium. The PSA response is a nice feedback that we're going in the right direction, and I think patients appreciate the fact that we can continue to use PSA as a biomarker of response, but this is something we would discuss with the patients, and radium is not excluded. I mean, if we do things properly, I think we can sequence going one from the other, one after the other, and we have used radium post-lutetium and we've used radium pre-lutetium. The issue is when you wait too long, you miss windows of opportunity.
Dr. Freedland referred to the Therapeutic study, very important trial. At least there was suggestive data from that trial that the intensity of PSMA PET expression was associated with the relative benefit of lutetium PSMA. Dr. Beltran, do you use that information in making choices about the timing of use of PSMA lutetium?
Yeah, I think the data from both therapy and vision suggests that the SUV mean is maybe a predictor, but this isn't something that's routinely being calculated. And so it may be in the future that might help in decision making. But I think for now, it's an active drug. I would want to give this drug I would like to maximize the number of life-prolonging drugs our patients get. And I think the safety data of knowing that we can sequence radionuclides is important, and also trying to figure out that window where you can give the radium. But I don't think at this moment I would use the PSMA PET, the SUVs to make a decision just based on the fact that we have, phase 3 data to say that it's effective.
For a patient who is chemo eligible, who would you be prioritizing to use cabazitaxel before a radionuclide?
I think that, definitely I wouldn't use radium, obviously in a patient that had non-bone mets, and in a patient that has PSMA positive disease based on vision criteria, but had significant PSMA negative lesions that were smaller, that would have, potentially been included in the trial, or maybe liver metastasis, sort of these poor prognostic patients that you don't think are going to necessarily do that well with lutetium. I might think about doing chemo, but you can still give lutetium after chemo. So, oftentimes just even because of the drug supply issue, I'm bridging people with chemo anyway.
Exactly. It is a hypothetical question at the present time, and we do look to hopefully having better information in the future about optimal sequencing and selection of patients. We have a couple of cases to discuss before our final presentation. So this is a 71-year-old man with PSMA-positive bone-only mCRPC who experienced disease progression on multiple lines of prior systemic therapy, including ADT, enzalutamide, CRPC, and I'll specify docetaxel. Which of the following therapies would you generally recommend first? Kind of a repeat of the general question I raised earlier, but now with a very specific case. Dr. Saad.
Yeah, I think it's going in the direction that we're going. I would be comfortable with both, but with the PSA response as a biomarker that we're going in the right direction, lutetium is becoming our
I think the way I view this is it's really strength of evidence, right? The Vision trial has the benefit of being a more contemporary study, included patients exactly like this. We just have less information from Alsimca. It was done at a somewhat earlier time. It is harder to evaluate response and resistance in patients treated with radium-223. PSA declines are not an expected outcome from that treatment, although they can be occasionally observed. And so I think based on strength of evidence, my preferred first-line treatment, including in patients with bone-only or bone-dominant disease, would be lutetium rather than radium-223. And I think the point that's already been made is you can sequence those therapies. Dr. Shore.
But in this particular hypothetical case, the patient hasn't received docetaxel.
I added that just to make
added that
a fair comparison.
Yeah. So, I get it. Okay, but yeah, based upon that, it's actually incorrect the way the folks have answered the way the question's positive without your caveat. And then there is upcoming data, the RALU study, radium and then lutetium. A lot of folks are concerned that there may be not adequate tolerability and excessive myelosuppression, and that's showing not to be the case in most patients. So, worth knowing.
They will be very important considerations. I mean, part of the challenge of having the current approval of lutetium PSMA so late, these are patients who often have very limited bone marrow reserve, and some of the cytotoxicities that we observe can be related to disease progression as much as the therapy that they're receiving. So the next question is, to what extent do you believe that dry mouth associated with lutetium PSMA is problematic for your patients? Dr. Freedland?
I mean, given the limitations of getting it, I don't think we had enough patients treated for me to answer that
Dr.
one.
Shore, you were involved in the trial, so
Yeah, so we were a VISION trial site. In fact, we were the highest enrolling urology site, a full-on homogeneous urology site with no medical oncologist or rad-oncs, except for the rad-oncs who gave the therapy and got the radioactive material license for using this particular beta particle. And I've given it now post-approval. It's really not very problematic. The dry mouth has not been particularly problematic. I think that there is probably more data coming forward that numbers of infusions could potentially correlate with it becoming more of a significance. I think the interesting thing to me, Matthew, is if somebody's responding after 2 or 3 cycles and it's indicated for 6 cycles, do you stop to try to avoid that additional toxicity?
Yeah, it is a fair issue. How do you think about the ongoing pre-chemotherapy lutetium PSMA study? The top-line results have been at least reported in a press release. We obviously look forward to the full details of that. So how do you think about that, Dr. Shore?
Well, I think it's really exciting. We participated in the PSMA-4. We've participated in the SPLASH trials, which are both pre-chemotherapy, mCRPC. I think it's great. It's like it really follows the traditional pathway of all of our approved drugs in advanced prostate cancer. We start at the most advanced and we move it up proximally. I think you'll probably find that the tolerability is the same, if not better. And adding to that, patient-physician shared decision-making discussion will be important.
Yeah, I mean, right or wrong, most, substantial proportion, probably about at least half of patients in the United States never receive docetaxel, including those with, fatal mCRPC. Some of that may be because they're not suitable candidates or they just prefer not to receive treatments. I think the ability to give an alternative treatment in that either chemotherapy ineligible or patients who prefer to avoid chemotherapy will be very important.
So I love your comment because when at the ODAC, it was pointed out to the FDA that in a recent contemporaneous study of 2,500 North American patients, Canada and the US, over 2,500, 78% got one first-line mCRPC treatment, 38% got a second, 16% got a third. That's inclusive of all the approved therapies today. So to your point, and less than 50% of patients ever receive a taxane.
Yeah, and I think this also highlights how important it is to optimally manage HSPC, because we're moving those drugs earlier. This should just be routine part of care. Help not only keep patients alive longer, but ultimately give them access to appropriate subsequent therapies. Dr. Beltran, your thoughts on this topic? How do we think about sequencing and optimal sequencing in prostate cancer, and how do we improve basically clinical practice in the community to see that our patients are receiving the right treatments?
Yeah, I mean, I really think that the numbers of patients getting docetaxel is really shocking to me because, it's been around for a long time. It's well tolerated. There's clear activity in later stages and earlier stages. Hopefully, drugs like lutetium PSMA moving earlier will, increase the number of patients getting these life-prolonging therapies. But I think it is a serious problem, and figuring out how to solve it, I think, is a longer discussion. Sure.
Well, thank you for those comments, and we'll move on to your session,
Sure.
looking at the emerging therapies in this setting. Thank you.
Yeah, thank you. So we'll now continue our discussion of mCRPC, moving a little bit to later stages of the cancer. This is just an overall timeline, just to highlight many of the drugs we talked about today. Really impressive drug approvals over the last decade, with the latest being lutetium PSMA-617, as we just discussed. So lutetium PSMA-617 targets PSMA, prostate-specific membrane antigen. That's a cell surface receptor. It does have a function. It's involved in folate uptake and some cell tumor profiling, but I think its function in prostate cancer is not well established, other than the fact that it's really a great biomarker and target expressed in nearly all prostate cancers at diagnosis, the majority of HSPCs, and about 80% of mCRPCs. So expression can be dynamic. It's not only expressed in prostate cancer, but also normal prostate, proximal renal tubules, small intestine, and salivary glands. Lutetium PSMA-617 is a beta-emitting radioligand conjugated to a small peptide that binds PSMA. And also, as we discussed, so it's approved post-AR therapy, post-taxane, based on the VISION trial, with requiring patient selection using gallium PSMA PET scans. The Therapeutic trial, so lutetium PSMA has been used for quite some time around the world, but the Therapeutic trial was the first prospective study to look at this compared to cabazitaxel. And as we heard earlier, that there was a higher response rate and improved PFS, though no OS benefit. But this encouraging activity in this late stage population was really the rationale for the VISION trial that enrolled patients post-AR, at least one AR pathway inhibitor, post at least one taxane. Patients were randomized to receive lutetium PSMA-617 plus standard of care versus standard of care. Just to note that in the standard of care arm, this excluded chemotherapy, immunotherapy, radium, or other investigational drugs. PSMA positivity was defined by at least one PSMA positive lesion and no PSMA negative soft tissue or visceral lesions greater than or equal to 1 centimeter, or lymph nodes greater than or equal to 2.5 centimeters. So a little bit of a looser criteria than the Therapeutic trial. The trial met its co-primary endpoints of rPFS and OS. Many of you have seen these curves shown here on the right. And so this is now, of course, approved for our patients. But just to note on the left that all patients had to have an AR pathway inhibitor, and about almost half of patients had more than one, and 40% of patients had 2 taxanes. And so this is a later stage population. Many patients have had cabazitaxel as well. Most common AEs, fatigue, dry mouth, nausea, anemia, with grade 3 and 4 being cytopenias and fatigue. The Therapeutic trial used not just PSMA, but also FDG PET to screen patients, with about 70% of screened patients being eligible. And in a more recent study, looking at the combination of PSMA and FDG, attempting to optimize our imaging parameters to develop better predictive and prognostic biomarkers. And as recently published, the odds of a PSA response to lutetium PSMA versus cabazitaxel was significantly higher for men that had SUV means of greater than 10 compared to those that were less. So the bottom right graph are the patients that had the SUV greater than 10 who received the lutetium versus less than 10 on the top panel. And this also has been seen in the VISION trial reported at last year's ASCO. This is not something, as mentioned, is routinely available on our current PET scans, but something that I think could be used in the future. What they also found is that FDG volume, so patients that were PSMA positive and FDG positive, tended to do inferiorly, suggesting that this may be a prognostic biomarker in the setting of lutetium PSMA. 12.6% of patients in VISION had PSMA negative disease and 28% in therapy. And some of these may be due to neuroendocrine differentiation or other mechanisms. And the patients that screen failed for therapy had a median survival of 2.5 months. And so we do need to think about therapies for this type of population as well. There's preclinical data to suggest that the FOLH1 gene, which is PSMA, is indirectly regulated by the androgen receptor. When tumors lose the androgen receptor, they lose PSMA. And so I think this is also important, thinking about new drugs that target the androgen receptor and thinking about how well they will work in the PSMA low or negative situation. So response to PSMA-directed therapy is not universal, although it is quite impressive in our mCRPC population, and the understanding not only the expression of the target, but also mechanisms of response and resistance will also help us thinking about other drugs that target PSMA that are now being developed in the post-lutetium PSMA setting, also in the pre-setting for certain populations, including actinium PSMA 617, other radionuclide therapies, bispecific T-cell engagers, CAR-T, ADCs, and others. And so understanding cross-resistance will help, as well as thinking about combination therapies. And there's also opportunities, of course, to bring this earlier, and the PSMA-4 trial, which we haven't seen the full data, has been reported as a positive for its primary endpoint of rPFS. I look forward to seeing this data and hopefully approval in this situation, as it does make sense to bring this drug to the earlier mCRP situation, where I think might be the sweet spot for PSMA expression and response to therapy. PSMA lutetium is not the first radiopharmaceutical that we've been using, and radium-223, as we also discussed, is a very important drug that is a alpha-emitting isotope that's bone targeted. And the ALSYMPCA trial enrolled patients with symptomatic mCRPC and bone mets and demonstrated an OS benefit, and it is approved. And just to note again, as we also discussed, that about a third of patients in the VISION trial had prior radium-223. They had to have had it at least 6 months prior. And then the retrospective RALU study also looked at radium before or after before lutetium PSMA, mainly to note that the safety seemed to be tolerable, not a higher incidence of cytopenias, and efficacy of lutetium post radium-223. So this seems to be a safe thing to sequence, which of course is important as we get new drugs and new drugs into our clinic. Cabazitaxel is another option for patients post-AR therapy and post-docetaxel. The CARD trial took patients that had progressed within 12 months on ABI or ENZA and had previously had docetaxel and randomized them to either cabazitaxel or the other AR pathway inhibitor. And there was an improvement in PFS and OS. So the cabazitaxel is also an active drug. And I think what this also established was that there's limited activity in sequencing AR pathway inhibitors because the patients that were on the control arm did quite poorly. We heard about genomic testing in the context of DNA repair aberrations, lots of considerations of which tissues to test, but beyond BRCA and that class of genes, pembrolizumab is approved in a pan-cancer indication for patients with MSI high, mismatch repair deficiency, or high TMB greater than 10. And although prostate was underrepresented in those pan-cancer approvals, patients can have significant responses. It's present in about 2 to 5%, and I think important to really look for. This is a patient of mine who had a ctDNA test that showed a TMB of 23, no MSI, and his PSA went from 100 to 5 in a really short period of time receiving pembrolizumab. So finding these patients, you may actually find exceptional responders, so just important to consider. Immunotherapy has not been really effective in an unselected population, but there have been a number of combination immunotherapy trials that have been investigated, including cabozantinib plus atezo, which in the COSMIC-021 study showed, in the early phase trial in the prostate cohort, showed responses, or impressive, I think, activity in a heavily pretreated population, including visceral mets, with a disease control rate of 80%. And this combination is now in a phase 3 trial. And then finally, new and emerging therapies for mCRPC. The androgen receptor is still a key driver of mCRPC, even post all of our AR pathway inhibitors, and there are a number of drugs being geared towards targeting the androgen receptor. As mentioned, there are a number of PSMA-directed therapies, as PSMA can still be expressed in patients post-lutetium PSMA. PSMA has also paved the way for other cell surface targets, TROP2, B7H3, DLL3, and others that have opportunities for similar types of approaches, ADCs, or even in molecular imaging. Targeting non-AR-driven disease is important, such as the neuroendocrine phenotype, targeting other genomic alterations, such as biomarker-driven studies looking at PTEN loss, and then rational combination strategies. As we know, this is a heterogeneous disease, but there's been a lot of progress, and hopefully we'll see more data from these early targets in the future.
Thank you, Dr. Beltran, and thank you to the rest of the faculty for their outstanding presentations and active engagement in the questions and the cases. Our thanks to everyone both in person and virtually for joining us this evening. Thank you very much, and have a good rest of your evening.